So what are some of the barriers identified in prescribing naloxone to this target group? Some of the identified barriers are in that it is a prescription-only medication. Without a legal prescription, naloxone cannot be dispensed, although some programs have managed to negotiate special directives. This is by no means widely available by directive in Canada. This is an area that certainly needs to be explored further. Another barrier is the physician's reluctance to prescribe because it is a new or emerging practice. The physician may not be aware of the naloxone strategy or have insufficient knowledge and confidence to prescribe it, or there may be belief of perpetuating drug use when prescribing it, or there may be fear of liability. There may also be negative attitudes towards drug addicts and also in harm reduction in general. This is not insurmountable with the appropriate education and the engagement of your physician peers, and this initiative is squarely on trying to reduce morbidity and mortality. Similar to insulin, naloxone is not produced in a form that can be readily used by consumers without other equipment and requisite training. In addition to the syringe and needle, other equipment and training on rescue methods needs to be part of the initiative. Delivery mechanisms like pre-filled, rapid injection, or intranasal devices, as I mentioned before, should be explored to improve usability. Finally, the cost of naloxone is not covered on the provincial formularies. So who can administer naloxone? Here are a list of providers who can administer naloxone. Physicians and nurses have been the traditional administrators of naloxone. However, as we know, amidst our opioid crisis, that this simply does not reach the target group entirely, in which the majority of deaths have occurred. Emerging practice is to prescribe naloxone to the actual individuals at risk of overdose. As I mentioned earlier, it is unlikely that the individual who is overdosed be in a position to administer their own naloxone. This relies on family, friends, peers, even bystanders to administer the naloxone before emergency services arrives. This then raises the question of possible liability. In Canada, from the perspective of a family member, friend, caregiver, or peer who has access or has been entrusted to hold onto the naloxone in the event of overdoses, many jurisdictions in Canada have recognized the Good Samaritan Act, which protects the individual from liability despite the rules of common law. When a person who voluntarily and without reasonable expectation of compensation or reward provides the services to the client, it is not that they are not liable for the damages that result from the person's negligence in acting or failing to act while providing services unless there's gross negligence involved. Only in Quebec civil law jurisdiction does a person have a general duty to respond, as written in the Quebec Charter of Human Rights and Freedoms. New Brunswick and Nunavut do not have Good Samaritan laws and would be governed by common law. The development of these laws is comforting, in which, with the hopes to improve the willingness to help in emergency situations without fear of legal repercussions. Sorry about that, synchronous. Also, as far as directives are concerned, an example of a directive in the use of naloxone in the treatment of suspected drug and opioid overdoses is in the members of the College of Registered Nurses of BC. It states that nurses can administer naloxone to treat suspected drug and opioid overdose. Note that this is only an administration directive and not a dispensing one. The administration of naloxone is guided by the Provincial Decision Support Tool, which provides province-wide and consistent practice for registered nurses. This tool, however, stops short of dispensing naloxone to individuals at risk of overdose, as in the case in other programs which have dispensing directives. What are the potential risks? Potential risks that have been articulated include responder needle to stick injuries, as well as not calling emergency services in event of overdose, recurrence of overdose, and also perpetuating drug use. Or unknown, randomized control studies would be difficult in an intervention of this nature. There are reports of a large number of overdose reversals of over 10,000, for instance, to date in the U.S. Any potential risk would likely to be small compared to the number of lives saved. As far as the effectiveness and drug efficacy, as we know, naloxone is used widely in anesthesiology, emergency rooms, first responders, whereas community prescriptions and take-home programs are emerging practice. For example, standard treatment algorithms published in the medical literature are well established and are effective in the reversal of opioid overdoses. The United States started distributing naloxone in 1999, and as of 2010, 183 programs were operating in 19 states. Some of the programs have published in the scientific literature. Naloxone has been distributed in San Francisco, for instance, since the late 90s, and with San Francisco Department of Public Health support since 2004. During that time, heroin overdose fatalities slowly decreased from the peak of 155 in 1995 to 10 in 2010. Opioid analgesic deaths, such as those from prescription pain medications, oxycodone, methadone, or hydrocodone, remain elevated, with 121 deaths in 2010. And efforts are underway to expand access to naloxone for patients receiving prescription opioids as well. Project Lazarus in North Carolina is one that has achieved some success in reducing death rates from 49 down to 26 per 100,000. In conjunction with distributing naloxone, this program specifically engaged physicians in an education program in safe prescribing of opioids for chronic pain, of which many of the deaths were attributed to, as was identified in the San Francisco project. In Canada, we have several take-home naloxone programs. Edmonton was the first, starting in 2005, and the Point program in Toronto started in 2011, and recently in Ottawa and BC started their programs in the last year. These programs are starting to report overdose reversals with their distributed kits. Other countries have also taken the same initiative to provide take-home naloxone, listed here. In the San Francisco Dope Project, overall 11% of all participants reported using naloxone during an overdose event. 83% of the interventions were reported to be effective in reversal. With emergency services involvement, 89% of all overdose events were successful where naloxone was used. In the majority of the reversals, participants indicated that they used revival methods taught during the training. However, an interesting finding was that the minority of respondents reported contacting emergency medical service after they had intervened. This is an area of initial concern that overdose deaths were occurring due to fear of calling 911, which needs to be addressed with appropriate training and education. In the U.S., there is more data. Based on the recent CDC Morbidity and Mortality Report recently in 2012, out of the 188 programs, 48 programs responded to the survey and reported a cumulative total of 10,000 overdose reversals since the inception of the respective programs. This is data which spans a 15-year period from 1996 to 2010. Despite the large number of overdose interventions, there has been a steep rise in the number of unintentional overdose deaths, the blue line here in the slide. Perhaps there is a flattening of the rise from 2006 onwards, which is unlikely to be fully attributed to the naloxone programs alone. The crude rate is still abysmal at 9 deaths per 100,000 when compared to that of 1 death per 100,000 at the beginning of the study period. How about cost effectiveness? This study by Coffin based their analysis on a kit that is $15 in value, naloxone, or $30 for an intranasal kit. Based on 1 life saved in 227 kits, the equality figure was $438, which easily meets the test of generally accepted threshold of $50,000 per quality of life year gained. In this analysis, take-home naloxone is cost-effective. As I had mentioned, there are 2 main groups of focus in which to target prescribed naloxone for overdose reversal: in illicit users and also in prescription opioid users. Heroin or other illicitly obtained opioids, as far as overdose deaths are concerned, are relatively well documented. Depending on your practice profile, you may see a few or many in this target group. However, all physicians come across chronic pain in their practice, and recognition of the risks and benefits of prescribing opioids in each and every practice would be necessary in order to address the second target group. If I use BC as an example, the peak of illicit overdose deaths was in 1998 with 417 deaths, not shown on this table. Due to local initiatives in harm reduction and Insight, the supervised injection site, opening in 2003, the annual death rate dropped to the low 200s. However, this table documents an alarming recent rise. There are over 100 more deaths in 2011 when compared to 2008. In absolute numbers, this is 294 deaths in BC versus 196. The majority of these deaths were unintentional. And of the 294 deaths, 69 were from Vancouver, which illustrates that the problem is not only in the inner city of Vancouver. Death associated with prescription opioids, that is, opioids obtained legally from the treatment or for the treatment of acute and chronic pain, or those receiving opioid treatment replacement therapy, is not well documented, as these deaths are not associated with illicitly obtained opioid, and not until recently have there been inclusion in publication. As far as BC is concerned, the ballpark informal number in BC is 80, which is not insignificant, and the summation of illicit and opioid prescription deaths would be almost the same as the deaths associated with motor vehicle accidents. It is important to note that deaths are uncommonly associated with opioids alone. In the sample of 223 overdose deaths in 2006 in BC, only 7 cases were found to have opioids only in their toxicology report. In 60 cases in which opioids were involved, there were other drugs identified, mostly cocaine. Also, 80% of the deaths tested were positive for cocaine. So the take-home message here is that of the deaths that occur, or those that would be risk of deaths, multiple drugs are usually involved. Now on to prescribing. According to the drug monograph, naloxone has been approved for the complete or partial reversal of opioid depression. It should be emphasized in the training that naloxone is not effective in counteracting other non-opioid sedatives, and also in emergency services. Emergency service should be caught before initiating intervention. In most programs, the dose is 0.4 milligrams from an ampule given intramuscularly to be used in addition to other resuscitative measures, followed by second dose in 5 minutes, and hopefully after which time the emergency services will arrive. As far as criteria for prescribing is concerned, naloxone should be prescribed on indication for the individual at risk, e.g. for an opioid user with informed consent, as with most other medical interventions from prescribers. It should also be prescribed to individuals who are currently taking opioids or who have recently been abstinent from taking opioids, and there is assessed to be an overdose risk. And also, if the individual is willing to undertake training in the use of naloxone and rescue measures. If you practice in a community that does not have a public program, it is possible to prescribe training in your practice using the materials prepared for this purpose by existing programs. A legal prescription for naloxone is required in Canada unless there is a special agreement in place authorizing the dispense, which would depend on your health region. In BC, the take-home naloxone does not have a directive in place, so a naloxone prescription is required. Currently, naloxone cannot be prescribed to a family member, caregiver, peer, or member or staff on behalf of a drug user, and cannot be given to anyone without the drug user's informed consent. These conditions mean that naloxone is restricted under prescription-only supply, and that supplies are not able to be held for general public use by people in settings such as homeless hostels or carried by outreach workers, for example. The conversation of prescribing naloxone would raise eyebrows if it is not judiciously combined with an opportunity to discuss treatment options. Of the approximately 90,000 illicit opioid users in Canada, only 25% are receiving treatment. Depending on their stage of change or where they're at, not everybody would be receptive to treatment. However, given any moment, there would be a significant number. I've prescribed over 100 naloxone kits, and many have asked me to start them on opioid substitution treatment or some other form of treatment like a weaning program or detox. It is important to note that most of all jurisdictions in Canada are improving access to methadone and Suboxone treatment, and this is an opportunity to offer this efficacious treatment. To dispel the myth of the lack of treatment, I'm using BC as an example here, and other provinces have a similar trend. Based on PharmaNet data, which records every community prescription dispensed at BC pharmacies over a 10-year period from 1996 to 2006, if we look at the blue line, the total of clients on methadone maintenance treatment in BC. There has been a steady increase in the number of methadone maintenance individuals receiving methadone from approximately 3,000 at the beginning of this time period to over 9,000, or a dramatic threefold increase. The red line affirms a steady flow of new clients starting methadone maintenance. The take-home message here is to note that methadone maintenance is available to individuals who meet the criteria for treatment, and no matter which community that you practice in, there should be a means of referring individuals into such programs. Another important area to consider at the point of prescribing naloxone is that if you also so happen to be the prescriber of opioids for pain. If you haven't done so already, I urge you to look at the Canadian Guideline for the safe and effective use of opioids in the treatment of chronic non-cancer pain. In this guideline, there are 5 main clusters of recommendations which is accessible on the website link at the bottom of the slide. This website is hosted by McMaster University and was created by a multi-jurisdictional group of experts in Canada, including our respective physician colleges. Based on an evidence-based analysis, they created the National Opioid User Group Guidelines. In this ever-increasing important topic, clear and concise guidance is provided to physicians to ensure safe and effective pain management and to screen individuals who are likely to get into trouble with opioid prescriptions. These guidelines have been published widely in the CMAJ and also the Canadian Family Physician and have been well regarded in the medical community. For example, if we review the recommendations in Cluster 1, deciding to initiate opioid therapy suggests a comprehensive assessment before initiating opioid therapy. There should be an addiction risk screener, perhaps ordering a urine drug screen at baseline, and also consider whether opioid therapy would be efficacious. This is grade A evidence. And also discussing the risks and benefits, and also consider tapering other drugs. Here is a screenshot of the risk screener. It is quick and easy to do in practice, and the opioid risk tool is widely used. Based on the scoring of your patient, you would end up with a low, moderate, or high risk. And it relies on identifying personal or family history of alcohol and substance abuse, as well as personal psychiatric history. A low score would indicate a lower probability of problems associated with opioid misuse, whereas a high risk categorization will alert the prescriber to those individuals who are unlikely to do well with an opioid prescription, and if it is the case, to review an alternative or less risky intervention which addresses the individual's pain. If an opioid prescription is still the best treatment option, the guideline offers a recommendation as far as monitoring the efficacy and the compliance, like structured opioid dispensing and urine drug screening. While not in the guideline, co-prescribing of naloxone might be considered here. Here is a screenshot of the take-home naloxone assessment I developed for the use at some of the inner city Vancouver addiction sites. This tool captures the salient features of the client's drug use history, which includes years of drug use, the context in which they use, either alone or with others, and the pattern of drug use. It also helps screen out individuals who are not opioid users who are not eligible for the naloxone. In the next tab, there is documentation of abstinent periods, which represent risk of overdose, as well as previous opioid overdoses and whether naloxone has been received in the past. In the final tab of the assessment tool is a workflow decision, or the decision aspect of the form, which ensured some thought be placed onto whether the individual meets the criteria for naloxone, and if so, to document the education that has been given, documentation of the physician order for naloxone, and also the dispense event. You don't have to have a fancy electronic system like this. A paper equivalent will also do. It is designed also to be part of, to be able to evaluate the program in BC. And finally, I'd like to say, as far as a summary, that naloxone is prescribing is an emerging practice in Canada. It is legal and available in Canada as a prescription, despite some identified barriers in cost, distribution, dispensing, and training. It should be part of a comprehensive program to address opioid-related deaths, to include education, prevention, enforcement, treatment, and harm reduction. Safe prescribing of opioids for pain cannot be overemphasized. This is an area that every physician and or clinician needs to be part of and learn the Canadian guidelines on the safe and effective use of opioids in the treatment of chronic non-cancer pain. And finally, seize the opportunity when you see your patients to discuss drug use in a non-judgmental way. Refer to treatment if your patient is willing, and be aware of the treatment services in your area. Thank you.